androgen, estradiol and estrone converted, and this madam has talked too much about SHBG, so we are not going in detail, but we want to see what we can offer this to which patient. Is these patients are suffering from insulin resistance? There are features of PCOS in this type of patients. Madam has rightly talked lastly that both lean and thin are affected. It is not that obese patient is always affected, and that affects number of systems, and reduction in this tissue response to insulin is the key. So insulin causes androgen production in patients with PCOS. Nowadays, madam has rightly said PCOS is not a disease, it's a metabolic disorder, and insulin is the amplified by LH response to granular cell and arrest in follicular development. What we can have this insulin-like growth factor, that IGF-1, that amplifies LH and androgen synthesis. It helps to regulate follicular maturation. So insulin-like growth factor binding protein 3 decreases in patient with ovarian hyperestrogenism, and when decreased, more bioavailability of IGF-1. So glycogenesis, insulin, gluconeogenesis, and peripheral conversion of glucose. This minus and this positive we have to learn during this presentation, that how adjuvant can help in PCOS patient when there is ovulation induction drugs fails. So if there is insulin, insulin causes +2 ovarian androgen secretion, granular cell, and ultimately it causes pain ovulation, and that we don't want in this type of patients. So elevated LH leads to elevated androgen, and that cause insulin resistance. What are the treatment? That depends upon the symptom and depends upon the patient goal. We cannot fit each and everything into the simple formula. It should be patient-centric treatment to our patients. Madam has rightly said we can give them lifestyle modification, and when we meet the person who has designed so much things of PCOS, they are told that 3 things should be done, just like entertainment, entertainment, and entertainment. In PCOS, one thing rapidly works, that is exercise, exercise, and exercise. Always ask them to see themselves into the mirror in the bathroom and believe that they look good into themselves. If it is not, then ask them to go for moderate exertion, weight loss. Believe me, at least 5% of weight loss will lead to give them good ovulation, and it is also effective in obese patients in PCOS. So weight loss improves 5 to 7% weight loss. It reduces ovulation, believe me, in 75% of patients. Decreases LS pulse amplitude and decreases androgen production, and it reduces insulin level. So what insulin sensitizer we can use? First and foremost is metformin. Most extensively studied, increased peripheral uptake of glucose, decreases gluconeogenesis, does not cause hypoglycemia. We should tell our patient that if you are not diabetic, this doesn't cause hypoglycemia, because whenever we prescribe metformin in early days, people used to say, metformin, why you are taking? You are not diabetic. This is a diabetic drug. But they don't know that extended role of metformin is insulin sensitization. It is relatively inexpensive, 500 milligrams, 60 tablets you can take. You can also take rosiglitazone. It is also again insulin sensitizer. It stimulates production of glucose transport to protein. There are lot of study of PCOS available in this rosiglitazone. Dose is 4 milligram BID, but little bit expensive. But our patients are usually affordable with metformin. But rosiglitazone improves clinical symptom, correct insulin resistance, improves ovulation rate, and very few side effects, particularly GI intolerance and fertility rate is not studied in this type of patients. How much treatment we have to give? At least 5 weeks. Ovulation rate 35 versus 4% in placebo. So imagine 35% of patient with insulin metformin can go in for ovulation. No ovulation, we can give clomiphene citrate, but clomiphene citrate with metformin increases ovulation rate by 90%. This is very good systematic illustration of insulin signaling and transferring pathway. When there is insulin resistance, it will go. In my presentation, you will see most of that in PI3 kinase, and that is the most important hormone in insulin resistance. Glucose 4 transporter uptake. You can see this glucose is coming down and going to meet this GL2U4 one by one, and there is insulin signaling transferring pathway is very well affected in presence of PI3 kinase. Okay, again she is going for second insulin uptake. So glucose metabolism there in normal cell, insulin binds to its receptor, form a complex called insulin receptor substrate, that is IRS. IRS stimulate messenger called PI3 kinase. Activated PI3 kinase activates GLUT4. Glucose is taken by GLUT4 through glucose channel for utilization of energy, and this IRS complex breaks down the receptor to relocate back and again is going up. So insulin resistance in polycystic ovary. Insulin resistance causes hyperinsulinemia. It causes high glucose level, decreased HSBC, increased testosterone in blood, and it will come polycystic ovarian disease. So insulin signaling pathway, how enzymatic pathway will work? Again, there is systematic IRS, that is insulin receptor substrate, stimulate PI3, that is phosphatidyl inositol 3 kinase. Metformin stimulate this. Glucose uptake is taken by glucose converted into translocation of GLUT4. Again, every glucose is going into this, and this is stimulating the transformation. Again, IRS, metformin stimulate this PI3 kinase. Transformation on GLUT4 and glucose utilization is occur one by one by this phosphatidyl. So phosphatidyl inositol 3 kinase is key messenger in insulin sensitivity. And we can see that there are so many things which can increase this phosphatidyl inositol 3 kinase. Not only the phosphatidyl 3 kinase activates stimulation of necessary for controlling PCOS, but also producing allopage stimulation is essential. So inositol acts as a precursor for PI3 kinase, and we can have lots of inositol nowadays available in market. So inositol deficiency is primary cause in polycystic ovarian disease. So when this oral ovulation doesn't work, there are more than 5% increase in the urinary clearance of inositol. Plasma concentration of inositol is reduced by half. So decrease in PI3 kinase activity, there is insulin resistance, and it will cause polycystic ovarian disease. So thus metformin not only right treatment for modality of PCOS, but we can have inositol, purest form of inositol is also necessary. Now we have got myo plus DCI. We have to see what dose should be given, how much is the duration in all PCOS patients, and what are the benefits. If you see, D-chiro-inositol acts as a peripheral tissue. DGI IPG, that is inositol phosphate glycan, reduces insulin resistance and increasing insulin sensitivity. DCI reduces the compensatory excess insulin production and hyperinsulinemia. DCI, by reducing the hyperinsulinemia, reduces conversion of MI to DCI at ovaries, and DCI spares MI for ovarian actions. What is the action of myo-inositol on ovary? MI normalize LH-FSH ratio, because we all know there is 3:1 ratio in PCOS patient. MI acts as a necessary messenger for hormone response. MI IP3 improves calcium 2 ion oscillation. We all know anything has to action from in to out. Calcium plus 2 is required as an oscillation. MI helps in oocyte quality, oocyte maturation, and pronucleus formation, and most important is conception. What is ovarian paradox? Emperizes as an insulin dependent enzyme. Why it is emperized? To activate deficiency in metabolic and respiratory organs. We all know that skeletal muscle and liver, ovary does not become insulin resistant. Reduces activity in emperimes, increases activity of emperimes. Reduces conversion of MI to DCI, leading to DCI deficiency, causes decreased conversion of MI to DCI, leading to myo-inositol deficiency. So if you know there is myo-inositol deficiency in ovary, there is DCI increase, myo-inositol deficiency, oocyte maturation arrest, and this is one of the cause of anovulation in polycystic ovary. It will cause oligo-ovulation and anovulation, and ultimately it causes infertility. If there is DCI insufficiency, myo-inositol DCI deficiency causes insulin resistance, will cause hyperinsulinemia, TH2 type 2 diabetes, hypertension, MES. So this is all leads to metabolic syndrome. That's why we are calling polycystic ovaries nowadays metabolic syndrome. Hyperandrogenism causes hirsutism, acne, alopecia, and all these cosmetic problems are always there with DCI deficiency. So myo-inositol affects a woman with PCOS. There is a very big meta-analysis study. The objective of that study was to assess the effect of MI alone or combined with D-chiro-inositol, that is DCI, on the endocrine and metabolic abnormality of women with polycystic ovarian disease. Results highlights the benefit of effect of MI in improving the metabolic profile of women with PCOS, concomitantly reducing their hyperandrogenism. This is again combined therapy with myo and D-chiro-inositol improves the endocrine parameters and insulin resistance in PCOS of young women with overweight, and this is very good paper published by this Brettinelli fellow. They enrolled 46 patients of PCOS and randomly assigned them in two groups. Whenever we want to do this, there should be two arms, A and B, treated respectively with association of MI plus DCI in ratio of 40:1 or with placebo, that is folic acid, for 6 months. The combined therapy of MI plus DCI is effective in improving endocrine and metabolic parameters in young obese PCOS affected with women. So again, this is big randomized trial by S. Crowley, that randomized double-blind placebo-controlled trial effect of MI in ovarian function and metabolic factor in women with PCOS. They done study on 92 patients. Again randomized, 47 received 40 microgram folic acid as a placebo, and 45 receives MI plus folic acids and myo-inositol 400 microgram with folic acid. Beneficial effect of MI in women with oligomenorrhea and polycystic ovaries in improving the ovarian function. How this will myo-inositol acts? Again, we saw this immunoinsulin resistance, that is IRS. Here the metformin, now there is myo-inositol also activates PI3 kinase. Same PI3 kinase, there will be glucose uptake, glucose is coming in, then there is transformation of GLUT4, and ultimately there is enzymatic signal causing this pathway, and we are happy that these patients are very well treated with this. Insulin signaling, again myo-inositol activates PI3 kinase, glucose is coming in, there is a signaling. So ultimate role of myo-inositol is what there? Increases insulin sensitivity by myo-inositol, decreases insulin resistance, improves glucose utilization, free and serum testosterone will be decreases, provide good quality of ovum, restores menstruation and ovulation, and improves pregnancy rate. Madam has described all this thing very well, that if there is a very good quality of ovum and we can transfer this very good quality of ovum inside the endometrium, then there will be a very good pregnancy in IVF, and routinely by this treatment they can get pregnancy by very well ovulation inducing drugs plus adjuvants. So what is inositol resistance? Although inositol supplementation is an effective treatment for large population of PCOS patients, around 35% are inositol non-responsive, or there is inositol resistance. So many times we can say that we had given MI plus DCI even though patient is not able to conceive, because that is because of the inositol resistance. So myo-inositol and DCI after oral intake are absorbed at the duodenum and jejunum level. Inositols are taken into the enterocyte using the same transporter of other sugars like glucose and galactose. SGLT1, that is sodium glucose transporter, through which inositol are co-transferred with the sodium from the intestine lumen across the intestinal wall. GLUT2, that is glucose transferase, by which inositol are released into the bloodstream. If it is not proper, then there is a inositol resistance. Inositol intake during meals may result in intestinal co-presence of different sugars, and that may compete for the same transporter, causing marked decrease in the inositol absorption. Inositol based drug for food supplementation like combined presence of sugary excipient of as maltodextrin, sucrose, galactose, etc. may be responsible for reduction of inositol absorption due to the competition for the same transporter. The presence of chronic inflammatory state of PCOS leads to a gut dysbiosis and metabolic disturbance. This can further reduce absorption of inositol as well as increase the insulin resistance. There is something like alpha-lactalbumin. Alpha-lactalbumin is globular whey protein that constitute approximately 22% of protein in human milk and approximately 3.5% of those of bovine milk. Also, it's also present in our milk. It is an important source of essential amino acids including tryptophan, lysine, branch chain amino acids like leucine and sulfur containing amino acids. It is broken down in intestine to release bioactive peptides which possesses prebiotic, antimicrobial properties, anti-inflammatory and immunomodulatory activities. We all know that pregnancy is immunosuppressive stage, and we have to thank our mother that our mother has generated enough amount of immunomodulation to implant ourselves into the utero. If we know the theory of allogenic immune response to paternal antigen, very much established by Professor Raj Raghupati, that so many times sperm recognized by uterus as an antigen. COVID had taught us lots of things regarding this antigen and antibody activity. Remember the second MBBS days of Robbins, in which we said when there is any antigen act into our body, there is formation of T and B lymphocytes. Against any antigen, there should be two response in our body, that is Th1 response and Th2 response. Whenever there is activation of Th1 response, there is formation of symmetrical antibodies, there is formation of increase in the destructive cytokines, and there is formation of increase in the natural killer cell. And these all are inflammatory in origin. So there is abortion of the embryo. But when there is Th2 response is activated, there is formation of asymmetrical antibody, decrease in the natural killer cell, all embryo protective immunomodulation is there, and all interleukins are there that is of positive nature. So embryo is ready to implant. Very good paper published by Clark and et al. In 1990. It suggests that why your mother has rejected you, and that has caused the immunological implants, that there is no proper environment in the uterus. There should be pregnancy conducive endometrium. Madam has rightly told that if endometrium is good, then embryo is going to implant. For good endometrium, there should be very good USSR score, there should be very good vascularity. If you cut the endometrium and see into the electron microscope, you can see very good pinopodal activities. You can see there is very good intergreen activities, particularly alpha V, beta 3 intergreens. They are occurring. And recently they have proved that there is a presence of osteopontin, and that is very much has got affinity for embryo to attract. And we are implanting ourselves by intrinsically by eroding the endometrium. After implanting ourselves, there is growth of embryo because of the syncytotrophoblast and cytotrophoblast, and this trophoblastic activity phagocytes the endometrium, and we are putting ourselves, and that is the first dialogue between the embryo and uterus. And at this juncture, uterus wants to decide that whether it continues the pregnancy or destroys the pregnancy. So alpha-lactobilin is broken down into intestine and releases bioactive peptides which are possesses prebiotic, antimicrobial property, anti-inflammatory and immunomodulatory. Recently in ASHRAE, madam, we have got very good discussion regarding the probiodata or microbiodata, that healthy vaginal endometrium is also required for healthy pregnancy outcome. If that lactobacillus score is very good, and that pregnancy will be conducive. It is administered orally. It passes undisturbed through the stomach, unlike all other proteins, and precipitated in gastric environment. Alpha-lactobilin absorption with MINDC. When there is MI or myoinositol or inositol resistance, alpha-lactobilin improves the absorption of myoinositol. Alpha-lactobilin offer the novel approach to treat inositol in responsive patient of PCOS. It can stimulate the secretion of GLP-2, that is glucagon-like peptides, which in turn increases the gene expression of SGLT and GLUT2 transporters. Alpha-LA also improves the permeability at the tight junction of the intestine cell and improves absorption of inositol. So co-administration of inositol plus alpha-lactalbumin may be more effective than inositol alone, and it is proven by clinical efficacy in so many inositol resistance patients. It also improves duct dysbiosis. Majority of women with PCOS exhibit duct dysbiosis, which is impaired in PCOS pathology. Alpha-lactalbumin acts as a prebiotic and improves gut dysbiosis that commonly found in PCOS patient. It increases level of lactobacillus and helps in reduction insulin resistance and gut inflammation. It broken down into various bioactive peptides and amino acids that are absorbed and have anti-inflammatory effect on the body. So if Manish says, then it is not good. It should be proved by scientific evidence. So this is study of myo-inositol plus alpha-lactalbumin. This is a clinical study. They had done study on PCOS patient with infertility of more than 1 year. Preliminary phase aimed to determine MI resistance with PCOS patient. 2 gram ionositol BID for 3 months, HOMA-R and plasma MI-SX, madam had rightly told. Main phases, previously selected MI resistant patient received the same daily amount of MI plus alpha-lactalbumin for 3 months. Ovulation was assessed by using ultrasound on day 12, 14 and 20 days of the cycle. HOMA index, lipid profile, hormone and MI level is evaluated and baseline at the end of study. Following MI treatment alone, preliminary phase, 23 out of 37 patients, 62% ovulate, while 14 patients, 38% were resistant and they did not ovulate. In latter group, MI plasma level did not increase. After the combination, 12, that is 86% of women unresponsive to MI, not ovulated, their plasma level were significantly higher in the baseline. If you see, the combination MI with alpha-lactalbumin allows significant progress in the treatment of PCOS MI resistance to re-establish ovulation, greatly increases chance of desired pregnancy. You can see this chart. This is the baseline study, and after giving both the treatment and results, and all these p values are very significant. So in all myo-inositol resistance patients, use alpha-lactalbumin. This is second study. 34 normal weight women or overweight, 14 in Mexico and 20 in Italy. That is a multicentric study. All aged 18 to 40 with anovulation and infertility more than 1 year with insulin resistance diagnosed by HOMA index. 2 gram of myo-inositol, 50 milligram of alpha-lactalbumin with 20 milligram folic acid for 6 months. Significant decrease at the level of 3 and 6 months in HOMA index and insulin level. Also in androgen level by testosterone and insulin level. No significant adverse effect were detected in both the groups. MI given with alpha-lactalbumin improves important parameter in PCOS with insulin resistance. So this are the percentage of changes. We can see this is study 1 and this is study 2. You can see all these things are decreased very well in the patients, and in myo-inositol resistance patient, simple treatment myo-inositol plus alpha-lactalbumin plus ovulation inducing drugs give them the benefit. Those are the patients, those don't want to go for IVF, they want to get the treatment. So in failed ovulation inducing drugs, adjuvant as a myo-inositol and lactalbumin is very good. This is another study by gestational diabetes. Women with diagnosed gestational diabetes mellitus were randomly assessed. They had given myo-inositol plus 50 milligram of alpha-lactalbumin plus folic acid, and another group has given control get only folic acid. This study was done for 2 months. Insulin resistance is decreased and preterm birth is very much less in this group of patients. You can see the gestational age, birth weight, large birth weight, CS in emergency, all things are very good, and patients HOMA index and insulin resistance index is going down. So MI plus alpha-lactalbumin volunteer absorption study, they had done study in 3 phases. Phase 1, all subjects, all fasting for 12 hours, receiving orally 6 gram of myo-inositol in powder form as a single dose, involved in 80 ml of water. Phase 2, after washout period of 7 days, same subject fasting 12 hours were given oral 6 gram of myo-inositol, 150 milligram of alpha-lactalbumin powder from dissolved in again in 80 ml. Blood samples was collected in pre-dose, that is 60, 120, 240 and 300 minutes after the post-dose, and significant increase in MI absorption with myo-inositol. If you see, these all are the patients, those they were given myo-inositol plus alpha-lactalbumin, and they had given very good absorption of myo-inositol on the hand or on the back of alpha-lactalbumin. So this is in vitro study. Alpha-lactalbumin increases myo-inositol absorption. Myolayer permeability for KSO2 cells following different experimental treatment evaluated, that is time of 4 hours. TEER, that is transepithelial electric resistance, expressed as a percentage of control on cell maintained. MI transepithelial percentage in KSO2 cell, that is transportation rate, was expressed as percentage. You can see this is MI and this is both. You can see the clearance or percentage of getting absorption is very well established. So major factor still left unaddressed is the direct insulin receptor sensitivity. and these are the paper published in journal that use of alpha-lactalbumin for the management of PCOS in inositol resistant women. Positive effect of lactalbumin in management of symptom of polycystic ovarian disease. This is also published in Nutraceuticals, and I am happy that our paper, that role of alpha-lactalbumin inositol in the treatment of PCOS, this is a review article and published in the Asia journal. Those who want, they can contact, I can provide this paper, and I have got my ORCID ID scanner that you can just download that scanner and you can get all my 96 paper publication in ORCID, including this paper also. So again, saying that insulin resistance, receptor pathway, second most important thing is vitamin D deficiency. What causes vitamin D? PDR, vitamin D deficiency, causing PPARD, and this will cause insulin resistance. So again, with all this PCOS patient, not only this inositol, myoinositol and alpha-lactalbumin, we have to add this patient with vitamin D3. Again, myoinositol increases PI3 kinase activity, insulin resistance substrates, glucose uptake and transformation of GLTU4 is very much high, and this causes PI3 kinase activity and ultimately lead to transportation of GLUT4, and glucose uptake will be very high. So you can see all this schematic diagram. Second most important, folic acid. Several studies have stated that the combination of myoinositol plus folic acid is more effective and comprehensive scoring in treating groups. Folate is an important for oocyte quality and maturation and implantation and presentation. We have to thank Professor S. Suresh that given the name of this folic acid as a engagement pill. You all know that those who are engaged in near future, they got married, and near future they become pregnant. Only thing by which we can prevent the neonatal defect and we can prevent the good quality of womb by supplementing good quality of folic acids in this all young women. So we have to give them the advantage of 5 mg folic acid as a engagement pill. So clinical evidence says that if you add this myoinositol plus folic acids, then the treatment rate will be very good. This is very good paper published by Constantino, that metabolic and hormonal effect of myoinositol in women polycystic ovarian. This is a double-blind study. This study says that myoinositol in a group of this all patients. Please go, I can read this. Okay. So this study says that ionositol plus folic acid improves insulin sensitivity. 42 PCOS were treated with double-blind study. In group 1, 23 women received myoinositol plus folic acid and 19 women received only folic acid with placebo. Treatment duration is 12 to 16 weeks of duration of this treatment. You can see that twofold improvement in insulin sensitivity in the patient with myoinositol and folic acid. This is baseline. You can see insulin sensitivity is very high. So myoinositol plus folic acid causes 36% reduction in the glucose, level. So it is very high. So you can add folic acid. Myoinositol plus folic acid gives 65% reduction in the testosterone level also. And 69% of patients ovulated well with myoinositol plus folic acid, and this shows percentage. So add myoinositol plus folic acid to get very good ovulation in all these patients with polycystic ovarian syndrome. Myoinositol administered positive effect on hyperinsulinemia and hormone parameters in overweight patient with polycystic ovaries. Very well studied by Enclerzo and all, and this is published in Italy. They have done study on 20 patients. In group 1 there is myoinositol, and group 2 only folic acid, and what they proved: insulin sensitivity expressed as glucose resistance and HOMA index, and menstrual cyclicity was also measured, and they can see that with this treatment menstrual regularity is there and patient is ovulating very well. 20 patients, group 1, 2 mg folic acid, only folic acid, testosterone, insulin level, HOMA index significantly reduced in myoinositol. Menstruation was restored in all these patients of oligomenorrhea. Again, very good paper. Myoinositol patient with PCOS, a novel method for ovulation induction. So you can see that all this resistance patient, we can use this myoinositol in all this group. There is 23%, 25 patient, 88 patient restored normal ovulation, spontaneous ovulation, and they can become pregnant. This is 90% of the pregnancy with myoinositol. That is 25 patients who treated with myoinositol constantly and gave positive pregnancy result, and particularly singleton pregnancy and twin pregnancy and fetal heart positive in 90% of patients. Again, very good paper of effect of myoinositol in PCOS by L. Cotta, and they had also done in two group. In one group 2 gram myoinositol and 200 milligram of folic acid, and second group is placebo. And ultimately they concluded that the myoinositol may be useful in the treatment of PCOS patient undergoing ovulation induction, both for insulin sensitizing activity and role of oocyte maturation. Myoinositol provides good quality oocyte in group 1, group 2 only folic acid, so significant reduction in the number of immature oocytes. Number of oocytes recorded at the time of pickup were found to be significantly greater, more than 50 with myoinositol group. Very good paper, and this is published in session 65 clinical ovulation in 2008 paper. All paper are very old, but they all says that comparison of myoinositol to folic acid with clomiphene citrate in PCOS patient. They had done study on 2 arm. Pregnancy rate was very good, and they concluded the myoinositol treatment capable of restoring the spontaneous ovulation and good quality of ovum, particularly in the patient of polycystic ovarian disease. They had done study on 75 infertile women, 36 patient myoinositol plus folic acid, another 39 patient of 50 milligram of clomiphene citrate for day 5. All patients were followed for 6 months. What they get result? Myoinositol is simple, safe treatment and should be a primary method of inducing ovulation in all these patients. You can see myoinositol plus clomiphene citrate gives very good ovulation. What is the evidence of vitamin D? Recently, vitamin D is getting very much well-established role in infertility, and you can see that recent days, so many inventions are in vitamin C, vitamin D. We have got chewable tablet, we have got nanosodes. Why it is that? Because all these renowned journals, clinical endocrinology, fertility, sterility, JSCM, all say this, that vitamin deficiency is newly identified risk factor in polycystic ovarian disease. 85% of PCOS women with vitamin D deficiency are associated with multiple metabolic risk factors. So all these patients should be added with vitamin D in all PCOS, because vitamin D deficiency causes insulin resistance, follicular immaturity, hypoandrogenism, menstrual irregularity, metabolic disorder, and ultimately what we don't want, that is infertility, and that is because of vitamin D deficiency. So vitamin D deficiency with insulin resistance causing hyperinsulinemia. Again, this is vice versa. Hyperinsulinemia causes high glucose level, decrease in HSBC, increased testosterone production. Ultimately, what it is, polycystic ovarian syndrome. Vitamin D regulates insulin receptor transcription through nuclear vitamin D receptor, that is VDR, that are distributed across the various tissue level like liver, pancreas, and ovaries. VDR sensitizes insulin receptor and increase sensitivity of insulin towards this receptor. Link to vitamin D insulin receptor pathway. Vitamin D3 binds with vitamin D3 receptor. It activates the peroxidase proliferation of activated receptor, that is PPR3. It stimulates the expression of insulin resistance, enhance the insulin metabolic glucose in the transporter department. So vitamin D deficiency leads to insulin resistance. So effect of vitamin D therapy on insulin resistance in randomized control trial. Mean age was 23 years, BMI is very high. Oral intake of vitamin D3 per day for 3 weeks. Nowadays we have got weekly administration of vitamin D3 also. And what they have proven? This is baseline. Vitamin D3 shows 21% reduction in the insulin resistance, 20% after 6 months of treatment of vitamin D3. Effect of vitamin D3 treatment on glucose metabolism and menstrual frequency against population in JEI. 57 women included in this study. PCOS women received cholecalciferol, that is vitamin D3, to 20,000 international unit for up to 24 weeks. Oral glucose tolerance test, blood analysis, and endocrine parameter was performed as baseline 12 weeks and 24 weeks. Results found: triglyceride level significantly decreased after 24 weeks of supplementation. Significant decrease in the fasting and simulated glucose after vitamin D supplementation. Vitamin D treatment improves glucose metabolism and menstrual frequency in all PCOS patients. So you can see that those patients who are not ovulating simply with ovulation inducing drugs, we can use as an adjuvant metformin, D-chiroinositol, myoinositol, folic acid and vitamin D3. So you to see that this is not a disease, this is a metabolic disorder. So all metabolic things we have to give to those all our PCOS patients and give them the benefit of all these adjuvants rather than keeping all these patients directly for IVF. Repeat vitamin D storage replete of after following the IVF, and this is very good study by Sabia Ozan, and they said that they want to do the study with vitamin D3 in all these patients. It is a cohort study, 84 infertile women undergoing IVF, and this is follicles, all the follicles are more than 14. Outcome was received that if there is vitamin D3 deficiency is there will be no successful outcome. So all these patients should be supplemented with 25 OH level. This is a prospect study of 84 women undergoing IVF cycle. Increasing serum concentration 25 OHD 2.3 times, increasing both implantation and pregnancy rate. You can see that implantation rate is very high, clinical pregnancy rate is also very high if supplements all these patients with vitamin D3. So ultimately conclusion, vitamin D3 supplementation successfully treats infertile patient undergoing IVF. Each nanogram per ml increases in follicular fluid or 23 OHD increases the likelihood of achieving clinical pregnancy by 6%. So vitamin D3 in PCOS increases HSBC, regulates androgenism, increases insulin sensitivity, correct metabolic syndrome and regulate menstrual cycle. Ultimately what we want is fertility after supplementation of this. Newer guideline recommended dose of vitamin D3 deficiency reproductive age 1500 to 2000 international unit daily. You can give 60,000 weekly dose also, that is also available in a nanosol. So in summary, it controls hyperandrogenism by reduces hirsutism and acne, regularize the menstruation cycle by increasing menstrual induces menstrual cycle, maintain menstrual frequency, insulin control, decreases insulin resistance, decreases insulin sensitivity. What we want in ovary? Follicular maturation, decreased immature oocytes. Because it is a metabolic syndrome, it reduces BMI, reduces triglyceride level and cholesterol, and hormonal balance by increasing HSBC and decreasing the testosterone. Another adjuvant, now there are marathon of different adjuvant that we can use, that is chromium picolinate. In October 2003, larger control trials confirmed that chromium picolinate efficiency PCOS patients could be potential for supplementation every day. Chromium supplementation could also help in PCOS patients. It is a short-term chromium has been used in up to 1000 microgram per day. It is also used as established. You can use melatonin in polycystic ovarian disease patients. Role of myoinositol and mannitolin supplementation in follicular fluid in IVF patient with polycystic ovarian syndrome. This is a randomized control trial by A. Picciotti, and this is study published in Italy. And most of the IVF patients, IVF-ET failure patients, they supplemented melatonin also. N-acetylcysteine in polycystic syndrome, a systematic review and meta-analysis of randomized control trial. They concluded that N-acetylcysteine also shows significant improvement in pregnancy and ovulation rate and study with after short-term outcome with placebo. However, the given limitation of existing study with such poor quality, less studies assessing live birth rate in future, well-designed determined control should be established. So N-acetylcysteine has got some role. We can also add as an adjuvant bromocriptine for hyperprolactemia and infertility. In all prolactin patient, increasing hyperprolactemia from 32,000, ovulation is very less and there will be amenorrhea. Macroadenoma, big prolactin, not bioactive, transition prolactinemia, pro-ovulatory 29 to 70 gram, and prolactin spikes usually in mid-time elevation. So if somebody wants to get right level of prolactin, they have to take blood at 4 am early in the morning. So bromocriptine decreases LH and prolactin, increase in the follicular steroidogenesis, increase in the follicular microenvironment. 2 milligram 2 to 3 times daily or intravaginally. We can use cabergoline, that is easily available in India, 0.0 milligram orally per week, and this will decrease bromocriptine requirement. Dopamine agonist can also be used for 12 weeks. Second is thyroid, hypothyroidism, difficulty in conceiving and fetal wastage, increased TSH, decreased T4 and free T4, Subclinical, increase TSH with normal T3, T4. You can give thyroxine 1.8 gram during pregnancy. Increased requirement, we have to titrate the dose during first, second and third trimester. So every 3 trimester we have to see what is the level of thyroid, and according to that we have to increase or decrease the dose of thyroxine. And thyroxine is available from 20.5 to 200 micrograms. So it is not titrating the dose. We have to give that titrated dose starting from 25, 50, 75, 100, 150, and we have to monitor every trimester, that every 3 monthly for the proper treatment. Then think about some Ayurvedic treatment. This is also paper published by us, that evaluation of efficacy of ovarial tablet in PCOS patients, and this is also very well established. Though if you want to give something herbal, you can use this ovarial tablet, and it also gives this. We have done study of 100 patients to evaluate the efficacy, and you can see that after giving all these things, there is very well, HOMA index is very well controlled, ovarian volume is decreasing, patient is ovulating, and insulin level are also decreased. And this is also available in a tablet form, and you can use this tablet when we don't want to use any hormone, and you can have a non-hormonal natural therapy. You can also use insulin 10 to 40 unit mixed hard in morning. This will give weight reduction, particularly in this type of patients, and you can use in these obese patients also. DHEA 75 microgram per day. We can use prednisolone at bedtime, because prednisolone decreases ACTH peak, decrease in androgen production, moderate GnRH release, FSH negative effect on pituitary. Dexamethasone not indicated because of high potency of long action. It has got very half cycle. It should be continuous for 3 months. Alternate day regime and maximum up to 6 cycle we can use. So many patients, for cycle regulation we have to use OC pills. It reduces the release of pituitary gonadotropin, particularly LH. Total free androgen produced from ovary. Hepatic synthesis of SHBC, bioavailable testosterone, sponge effect, and you can give those treatment for 3 to 6. Now something regarding the adjuvant in IVF. What are the factors? What we want? What adjuvant we can use when there is a ovulation induction drugs fail? We have to go for assisted hatching, PGD. Other method, we can give acupuncture, endometrial biopsy. And what are the drugs we can give mother to improve IVF outcome? Aspirin, glucocorticoids, growth hormone, DHEA, sildenafil, heparin, immunoglobulins, and sometimes antibiotic. We all know this assisted hatching. Now again, laser is very well, and with laser we can have this rupture of this wall by laser, and there will be artificial hatching of this blastocyst, and it is very well established, and laser hatching gives very good results. If woman is older, poor embryo quality, thick zona, repeated 3 IVF failure, we can use this assisted hatching in our patients. All these patients, we can go for PGD either by blastomere, either by trophoblast, either by polar body biopsy, and we have to give good quality embryo into the uterine endometrium. These are the indication in which we can go for PGD. What are the maternal factors we can use in our patients? Aspirin. We have to give 150 milligram of aspirin at bedtime, because we all know that aspirin has got circadian rhythm. It should be given at bedtime. Properties of arachidonic acid, less than cyclooxygenase, decreases Th2 thromboxanase, effective vasodilatory, anti-inflammatory, and platelet aggregation effect is there. We can also use aspirin after following embryo transfer, 75 milligram. Low dose, because very good established class study, that is corroborative study of low dose aspirin in pregnancy. It will increase the ovarian vascular flow, increases folliculogenesis, uterine receptivity will be there, and live birth rate is 23%, 27% with aspirin and 23% without aspirin. This is a randomized controlled trial of more than 1,400 patients. You can add glucocorticoids, that is dexamethasone, in our patients if you want. Somebody in some prescription, you can see that dexamethasone is also included, because it causes immunomodulation, increases intrauterine environment implantation rate, decreases natural killer cell, decreases inflammatory cytokines, and endometrium inflammation is very less with dexamethasone. We can use 1 milligram of dexamethasone or 10 milligram of prednisolone. Implantation rate is very high in this group of patients. Pregnancy rate is also 26.9%. Cancellation rate is very less, and pregnancy is established by this group of in Cochrane study by 2007. Somebody also included growth hormone adjuvant. It is intra-ovarian IGF-1. Addition of IGF-1 to gonadotropins demonstrate a very good study in animal and human. Gonadotropin action in gonadotropin cell is poor responders. It agglutinates, increases E2 by 17 beta and P4 and LHR. Augmentation of follicular development is there, and there is hypothesis for the induction of GH to enhance ovarian steroidogenesis for follicular development and ovarian study, particularly in cases of polycystic ovarian syndrome. This is the dose we can use GH hormone 4 to 12 international unit starting on the day of ovarian stimulation with all gonadotropins. Retrieved oocytes is very high, pregnancy rate is more than 60%, no significant difference in number of follicle, oocyte, gonadotropin dose and cancellation rate. No support for the use of GH as an adjuvant in this type of therapy, but if needed we can use DHEAS. Previously has got very good role. People are using too much dihydroepiandrosterone in all this group of patients, and they found that ultimately every year if you go in X-ray, 1 year they established that this has got very good role, and second year they said this has got no role. They started with 100, they started with 150. Every time it is different. Most of the studies with woman ovarian disease, decreased ovarian response may augment with ovulation induction. DHEAS, you can use sildenafil as a vaginal adjuvant, which will increase the vaginal blood flow, and so many effervescent sildenafil site is available. Sildenafil is also used for ovulation stimulation. It will increase the uterine blood flow. In the patients of APLA, you can use heparin, and we have to use heparin up to 34 week of gestation. Or we can also use immunoglobulins before embryo transfer. Result says that no improvement and no benefit, but some people are using antibiotic is useful if there is a vaginal antiseptic, or you find that there is infection, you can give antibiotic, but it is a controversial rule. Acupuncture, they said it is very full useful in China, but I had not seen that any patient can allow this much of needling in their face. But the beneficial effect is very well, that they cause that it increase in the vascularity. Sometimes in difficult we can go for pipelle, and always implant the embryo at the maximum implantation potential point. So they concluded that there are so many adjuvants we can use in this type of patient. Growth hormone we had already described. So take home message: treatment is to be guided by patients. We should give them lifestyle modification, protect the endometrium. Always see that embryo protective endometrium is there. Always see that in all PCOS patients, those who are not ovulating, with simple clomiphene citrate and letrozole, always try to add something like metformin, minoxidil, D-chiroinositol, vitamin D3, folic acids. Madam, you are speaking, madam. Your phone is speaking. Just mute them. X-ray post. This is my X-ray paper publication on PCOS. We had used in all PCOS letrozole and clomiphene citrate with this all adjuvant. So main need his difficulties because they are necessary to enjoy the success, and ultimately our all patients should be happy. And the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here. Thank you very much. Still we have got 10 minutes for discussion. And thank you ICOG for giving me opportunity to speak on adjuvants. And this is my yes, madam. These are resistant, so I had add all the adjuvants. That's why, madam, I told that. Yeah. Oh. Yes, madam.
become.
Hmm. Thank you very much, madam. Thank you. Any questions you can ask. We got 37 participants. Those who are there, you can ask anything regarding polycystic ovarian syndrome, roll of any adjuvants. Those patients, those who don't want to go for, madam says, though there is ovulation CC resistance and those are not going to go for IVF, they can have this mid-cycle way. Otherwise, you can induce all these patients with gonadotropin. And madam had rightly said that gonadotropin with metformin gives very good result. So always combine them in patients of PCOS. Vitamin D3 has got very good role. Madam will agree with me that all these patients should receive sufficient dose of vitamin D3. And all we are sitting in all these AC rooms, we all have got vitamin D3 deficiency, because vitamin D3 is usually available by sun rays and in early morning sun rays, and I don't think that anybody of us, madam, we are going in to get vitamin D3 from this sun bath. So we have to take vitamin D3 supplementation, and research has proved that vitamin D3 has got very good role, particularly in PCOS patients. There are resistance of myoinositol, madam has already, it is a trial based, but there are lots of paper. You can see this myoinositol. Yes, madam. Madam, you will be happy that after 3 months you will get one paper from Dr.Manish Pandya, and that will be my 97th paper. We had done study on 200 patients. We had done study on 200 patients, madam. Yeah. Hmm. Yes, madam. Yes, madam. Yes, madam. Yes, madam. Yes, madam. Yeah. Only myoinositol, and you can see that for after 3 months, what you get ovulation or not. There are very less number of percentage of patients those who become pregnant. That is 15 to 18% of patients. But believe me, that 18% of patients with a 3-month treatment of myoinositol, deinocassode, and alpha-lactalbumin is very good number pertaining to those 15% of patients not able to go for IVF. They are already taken lots of drugs. These are the group of patients who had came to Madam X, Madam Y, Madam Z. They had given clomiphen citrate, they had given letrozole. Patient don't want to go for IVF. Patient has got no affordability for gonadotropin, and if you want to give them, try. Yes. But madam, where but madam, if we don't use combination, we use only myoinositol, D-hydroinositol, and alpha-lactalbumin, and we will see the effect, then it is a good study. Yes. Okay. No, it is nothing to do with calcium plus 2 is also established role. Any questions from any students, ICOG students or reproductive? Yes, madam, their question. Okay, thank you, madam. So thank you, Nilima madam, thank you madam, and madam has already gone, switched off. Any question you can ask, otherwise we can leave this meeting. And thank you very much all the participants for patient hearing, and have given lots of adjuvants that you can use when there is a ovulation, induction, resistance of the patient with clomifene citrate and letrozole. Thank you. Gurveen Kaur madam, would you ask something? Because you are smiling. Because camera is on madam, ऊपर वाला सब कुछ देखता है. Thank you very much for patient hearing, and now I can leave the meeting. ICOG team, if somebody is there from ICOG office, Nilima madam or someone, or should cut down this transmission. Thank you very much. Thank you everybody, and namaskar, and all the best for your exam.